Hello, I'm Dr. Gretchen Tietjen. I'm a professor emerita at the University of Toledo, and we are going to be speaking today on an article, and I'm going to have my colleague, Anna Pace, introduce the article and summarize it for you.
Hi, everyone. My name is Dr. Anna Pace. I'm an assistant professor of neurology and the headache medicine fellowship director at the Icahn School of Medicine at Mount Sinai in New York. Today, we're going to be talking about a really interesting article that I was super excited to see was published in the journal called Migraine, Migraine Disability, Trauma, and Discrimination in Sexual and Gender Minority Individuals. So as I mentioned, I think this was a really great study, and I was actually very excited to see that this was published because there's such a significant dearth of literature on sexual and gender minority individuals. So this was really refreshing to see that someone finally was looking at migraine and disability in sexual and gender minority individuals. So the study by Rosendale and colleagues really sought to determine the frequency and severity of what they termed migrainous headache in sexual and gender minority adults, and also examine the relationship between a history of trauma and or discrimination and how it relates to migraine-associated disability. One of the things I did want to discuss really quickly before we go kind of delve into the summary is actually what sexual and gender minority individuals, what that term actually means. And is an inclusive term really used to describe individuals whose sexual orientation or gender identity don't align with societal expectations based on their sex assigned at birth. So it's including but not limited to people who identify as part of the LGBTQ plus community. So for the time being, we'll just use the term SGM to mean sexual and gender minority individuals. So we already know in cisgender women, as well as adolescents, that there seems to be a link between a history of trauma and a greater prevalence or increased severity of migraine, but we don't have this data in SGM individuals who we know have a higher likelihood of history of trauma or discrimination, things like interpersonal violence, sexual assault, physical assault, discrimination, and stigma. So one of the things that this study really looks at is trying to determine for those who identify as part of the LGBTQ plus community, if they have a history of trauma or discrimination, do they also have headaches? Do they meet criteria for migraine? And if so, what is their disability related to their migraine headaches? So the study was a cross-sectional study. They created a 68-question survey and then sent it to individuals in the PRIDE study. And the PRIDE study basically is a national online prospective longitudinal cohort of SGM adults, and they're looking at basically the physical, mental, and societal health. So it's the largest database that exists currently. And the survey was offered basically to anyone who had a self-reported history of headache, and they determined that by a general screening question. And then individuals were identified as having a migrainous type of headache using the ID migraine screening tool. They also then included the MIDAS scale to help quantify migraine-related disability. And then they asked questions about whether or not the individual had a history of trauma or discrimination in the past. And they kind of grouped those as kind of three variables, either trauma only, discrimination only, or a history of both trauma and discrimination. And basically what they found was actually of the population that they were looking at, 52% of those actually screened positive for migrainous headache based on the ID migraine criteria. 40% were identified themselves as transgender, genderqueer, or another gender identity. And 98.6% reported a non-heterosexual sexual orientation. So it was a pretty good sample of SGM individuals. They found that the gender minority respondents were more likely to have migraine headache, and those with migraine also reported a history of trauma and or discrimination, about 93% of them actually, and 72% of them had both. Those with migraine also were more likely to report a lifetime history of depression, current depression, anxiety, and PTSD. And this will kind of come up a little bit later when we talk about some of the variables in the relationship with disability related to their headaches. There didn't seem to be a difference in the number of migraine headache days that were reported in those who had a history of trauma and discrimination and those without. But they did find that those who had a history of both trauma and discrimination had a higher likelihood of having moderate severe disability related to their headaches. And that persisted even after adjusting for sociodemographic and clinical factors, but not for psychiatric comorbidities. So that kind of raises a number of questions that we'll hopefully talk about in a minute. And it seemed that the greater number of types of trauma and discrimination was associated with an increased migraine disability, even after adjusting for the psychiatric comorbidities.
Okay, well, I'm not going to add anything to that because I thought, you really summarized it beautifully. My area of interest and research, probably for 20 years, one of the things that I've been interested in is trauma, particularly early life stress, childhood trauma, but childhood trauma in addition to then adult trauma and how that relates in general populations, and including the subset of migraine. And I had looked at that in like the ACE study, as well as in the migraine AMPP study, American Migraine Prevalence and Prevention Study, and in the AdHealth study, which was adolescents populations. And just sort of having reviewed that literature, I thought for people that, before we sort of say like, okay, so what does this add to the literature? It's nice to just have a little summary of what the literature is. So I thought I'd just talk to that a little bit. 12 to 14% of the population is thought to have migraine, and the peak prevalence is in their 30s. In this population, the mean age was in the mid 30s area, and so I'm not sure that the 33% of the population that we found in this group is that different, but it's not really compared to a group, so we can't really say too much about that in general. I think what really did strike me was the percentage of people in that group migraine that actually had trauma. I mean, 93% or something. That's huge. There was an interesting study that came out in 2018 that was a systematic review, and they looked at PubMed and Ovid and the UNICEF databank, the UK database, the WHO over a 17-year period. And there they found that 20 to 40% of women, depending on the type, had experienced some abuse, and males, it was like lower, but 13 to 24. And so you could say about 20-25% of the population report some history of abuse. And, trauma has in many studies been associated with trauma and abuse have been associated with migraine, and particularly chronic migraine and the high disability. And you had alluded to some of those studies in adolescents and in women. And the more types of trauma, almost all of them have shown that dose-response relationship. And the more trauma you have, the stronger the association. So, that I think was an important finding. If they hadn't found that, I would have been very surprised. So, and within the migraine population, which most of the studies that have been looked at, they're mostly women. It looks like it's a little higher, and the odds ratios are usually in the 1.6 to 2 range for, if you in a migraine group, for if you have a type of abuse, and it's stronger in certain abuse types. Like a couple of the studies that I looked at, it was really the emotional abuse, which is probably more insidious and more constant over time than some of the other abuse types might be. And that migraine, as we sort of saw in this study as well, is associated with depression, anxiety, and PTSD. So that was something that was interesting. But I think the other thing is that there have been some studies that I just wanted to mention here when we talk a little bit more that have suggested that it is, I had in my studies just looked at abuse and migraine as a relationship. We looked at one with mediation through neuroticism, because that neurotic personality type is more common in those that were abused and in migraine, to see if it mediated, and it played a small role. And most of the studies have controlled for depression and anxiety like this one does. But you don't see as many studies on PTSD and migraine. I had done one, it was mostly in men migraineurs, that had the association to PTSD. But two studies, one I can think by author, last name of Raphael, that I think was published in about 2005, was a pain investigator, and then Todd Smitherman, who's a psychologist that works a lot in migraine. Both of them had reported in different types of studies, but that they thought that the main association was with PTSD and pain, or PTSD and migraine, and not in the trauma itself. So, since all people with PTSD have had preceding trauma, that's why it's PTSD. But if they looked at those that had trauma but did not have a history of PTSD, they didn't find that there was an association with migraine or with pain. And that's a little problematic, and there's not been many studies that have looked at that. So I think that kind of comes into play when we talk a little bit more about this one. But, to me, what the paper added, and I'm certainly not an expert in the SGM populations, but it seemed like it was the first study, at least I know, that I had looked at, and you can correct me if I'm wrong, but that looked with such detail into all the different groups of both sexual orientation identification and gender identification, and really kind of separated them out, at least for when they were stratifying by migraine, non-migraine headache, and no headache, and looking at some of the overall statistics of prevalence in the groups. And I thought that also looking at, the whole thing of trauma and migraine disability, and adding that discrimination thing, or actually I think their discrimination variable was discrimination and harassment. But given that this group, probably experience discrimination on a very regular basis, I thought that it was, interesting, and really I'd like to know more about that, since they didn't find discrimination by itself to be a variable that was associated with migraine disability. So I sort of took away the main findings being that migraine is really common amongst SGM adults, and that the experiences with trauma and discrimination together is associated with increased migraine disability, and that dose response relationship is there, and that the number of trauma experiences and their discrimination really strengthen the association and of trauma and discrimination with the migraine disability, even when they adjusted for the psychiatric comorbidities. And that, certainly in this population, it looked like psychiatric comorbidities play a really significant role. But I think that that's true of most things. And until you compared a group like this to a control group, which of course this wasn't a controlled study in that respect. It was everybody was SGM that was in the study. It would be really interesting to see, what the differences might be compared to, cisgendered individuals and people with a heterosexual orientation.
Completely agree. I think, one of the things that I found really great about this study is that it did look at a number of different people who identify across the spectrum of gender identity and sexual orientation, which we really don't have in neurology data or headache data at this point. And as you mentioned, the predominant population that was studied in the study were SGM individuals. I think there was only 1% who identified as heterosexual or cisgender. So the population really is uniquely SGM, which is, again, I imagine many of us are seeing a lot of these patients and don't know that they may identify in the LGBTQ community. And so one of the other things I wonder is, for some of these studies that have been done in the past for patients who have a history of trauma, PTSD, depression, anxiety, and high disability with their migraine, how many of them actually now, if we were to actually ask the question, identify as an SGM individual? And if so, how does that does that change our interpretation of some of these studies? I think one of the limitations to the study, as you kind of already alluded to, is obviously the complex relationship between migraine and psychiatric conditions. And, the study didn't really look specifically at the incidence of PTSD related to trauma and how that may mediate migraine-related disability. I think one of the other things that we do need to acknowledge is that they use the ID migraine screening tool, which from my recollection has a sensitivity of roughly around 80–85%, and may have missed patients who have migraine with aura, or for people who, the question they asked was whether or not headache is limiting their ability to do their day-to-day routine, if that's self-selected for people who already have a higher likelihood of disability related to their headaches. Selection bias is another thing to think about here, especially because the study was, I guess, advertised to the PRIDE study participants as one specifically looking at an experience of headache and how it's influenced by a history of trauma. So perhaps the people who were answering had a higher likelihood of history of trauma.
Right. I do think, though, that the fact that, they were sort of self-selecting with that question for people that had probably higher migraine associated disability, because if you didn't answer that question, you had to have only 2 out of 3 questions, so maybe that was one you didn't have. But on the other hand, since you're advertising it like that, it probably does self-select for people with disability. But then they're taking the disability and looking at it associated with trauma, which wasn't, I don't think, in the main question of what they asked.
No, I think they originally screened for headache first, and then if the patient tested positive, I guess, for the ID migraine, then some of the other questions.
So I think they probably, it was a biased population, and as they mentioned in their limitations, to do this kind of a study in a similar population, but maybe a larger population where that's a subset and you really sort of have a control and you could generalize the findings a little bit more with it. So I think that it's a great start, but you have to start with something like, with a population. I know that we did one where we were looking at migraine and abuse and wanted to see if there was an association. Well, we started with, a population of migraine and just looked at types of abuse, how common it was, how frequently the headaches were chronic, how many comorbidities they had. We could do all those things, but what we couldn't say was that migraine was associated with abuse, you know what I mean? Because you didn't have that control group. And this is kind of the same thing. You can't say SGM is necessarily associated with trauma because you don't have a non-SGM population other than historical controls to compare it to. But that the questions they asked, I thought, were valid questions to answer with the database. It's just that there's more definitely we'd like to see.
Right,
and
absolutely.
One of the other things that I had thought about, and when it came to the whole maybe it being a mediator, and you'd think that if you control for it and you still have some elevated odds ratio, that you'd say, well, it's partially mediating the relationship between disability and trauma. And if it totally disappears, as it seemed to in this one, when they looked at disability, migraine disability and trauma, then you'd say, well, it does look like it could be a mediator of the relationship. But there are other kinds of ways to get at that whole mediation thing, which I didn't think that they did. Recently, there was a study published in a Canadian study, prospective study published in Children, and looking at it with abuse and migraine. And one of the things that they did was kind of a structural equation modeling where, they found there was a direct relationship between abuse and migraine, and that it wasn't mediated through depression and anxiety for actual abuse types, where if they took like just sort of household chaos and dysfunction, they looked at that earlier and they found that that did seem to be mediated by depression and anxiety. And I was interested in that because I had done a study a couple of years ago that we presented at the AN, where we did it in the Ad Health population, which they were adults at the time, but they had been followed since they were children. And there we found in a structural structural equation model that the variable of different abuse types all associated directly with depression, associated directly with anxiety, directly with migraine, and that my depression and anxiety didn't mediate the relationship. And so that's why with this one, and it's, that they found that of course, they didn't look at migraine per se, they looked at, since there wasn't a control group, but they did look at the migraine, disability. And they did find that it, disappeared, which would suggest that it was a mediator. But I'd like to have seen a little bit more on that, because I think that's kind of a really interesting thing, because it's sort of one of the things that PTSD was in the pathway from the trauma to the PTSD to migraine, as they implied. What if they had done it where they looked first at anxiety and depression? Maybe they would have found it, maybe they wouldn't have, but then looked at PTSD maybe separately, since that's a really kind of novel way to, we don't have a lot of PTSD in a lot of these studies.
Right.
Like this on migraine per se. So I thought that would have been really interesting to me, to make sure they weren't over adjusting and losing the significance just because it was already in the pathway. So.
Yeah, I mean, I think this is a great start, and especially given the lack of data that we have on SGM individuals and neurology and headache in particular. But I think it has opened up a lot of opportunity for future research to really kind of delve, as you suggested, a little bit further into the complex relationship between some of these psychiatric comorbidities, gender minority stress, which has been discussed as possibly related to increased disability in these patients, and the incidence, prevalence, and severity of migraine. I think one of the things that we can kind of take home as part of this study as providers is really thinking about our patients who have a history of trauma, whether they're cisgender or identifying as part of the LGBTQ plus community, as well as some of the, discrimination events, as well as barriers to access to care, and how we as providers can really think about these, as well as, think about how it may affect their perception of their migraine, their disability, their ability to work, to go to school, to socialize, and those kinds of things. I think it's just a nice reminder of thinking about the whole person and not just migraine itself when we're thinking about treating them. And just having this data, I think, to start is a really great place for us to kind of, really ponder what else could be at play for these patients when, they're experiencing migraine frequently or very severely, and what we can do as providers to really help address all of the contributors to, or potential contributors to, their migraine disability.
Yeah, I think so. And I think that, a couple of things that I was thinking of it as from a clinician standpoint is, since you're right, you have to screen for it, because if you don't know the person, is in an SGM community, then you may not be thinking as much about the right questions to ask. But I think since trauma is so common in particular, and to assure that people, when we see them, to ask about it and to make sure that they're living, that they have a safe living environment, a safe working environment. Because a lot of times people don't ask about that. And I think that that's something where just being asked about it, they have to make their own decisions, but sometimes there are things that they could potentially alter, at least in their home environment. But I think the other thing too, I was thinking about is that both discrimination and trauma, I mean, those are really stressful experiences. And these people, it probably, can be a regular occurrence. Maybe it's been an occurrence through their whole lives, it doesn't really delve into it. And so I think that prescribing therapies besides for migraine, of course, but also make sure to include therapies for stress management, whether it be mindfulness-based stress reduction therapy or some other cognitive behavioral therapy, which we know is effective in migraine. But I thought that would be something that, would probably be something that might help them from of managing their own stress so that it doesn't have such a bad physiologic effect on them, because that affects the health of the rest of your life. And the other thing too is that, it's well known that people that have experienced a lot of traumatic events early in life, the data shows that their life expectancies are lower. And if they have like more than 6 ACEs, adverse childhood experiences, they have a 20-year decrease in their life expectancy. Now, some of it's because of the physiologic effects it has on the body, and you're more prone to atherosclerosis and hypertension and some of those things. But another, I think, big part of it is that people who experience a lot of trauma and potentially stressful discrimination is that they have a lot of health behaviors that are very unhealthy, or their behavioral risks, like smoking is higher, substance abuse is higher in populations that have experienced trauma, impulsive behaviors, reckless driving, just putting themselves at risk. And that is one of the reasons why a lot of the there's a higher mortality at a younger age in those populations. So I think that it's really important to probably screen for some of those things as well. And they did mention that depression, anxiety, PTSD maybe are potentially modifiable risk factors for their migraine and their migraine disability. We don't even know that in regular general populations. If we just control their depression, we do it, but if we just control their depression or control their anxiety better, will that make the actual migraines better? But I think it's something that's a really good question that they were asking for that. One of the things that I thought about, though, when we were talking about some of the other things of what we'd like to see next in the research, was I would have loved to have heard a little bit more. They had a really broad question of just, their trauma, but really know like the different types of trauma play a role in affecting their migraine, the severity of their migraine, severity of the disability, severity of their depression, anxiety, all that kind of thing. I would have liked to have known more, because it really does look like in other population studies that it does play a role. Certain traumas are worse, and also the severity and the frequency of the trauma. I think they did get that at that a little bit. The age at which the traumas occur make a difference, and the perpetrators of the trauma, did they have a good support system? Maybe trying to do things like building resilience. Are they resilient individuals? Can we, test that and sort of capitalize on that? And also to know if in these populations, do certain treatments work better than others? Do they do better if you treat their depression, anxiety, and give them stress reduction techniques than, in addition to their migraine remedies, rather than just treating migraine by itself? Do they need more? So I had done a study once where we had a group of all migraine. And so we looked at, and we took all the ones that had depression, since it was a large part of the group, since it was a headache clinic-based study. So, a lot of patients are depressed. So we took all these patients that had depression and migraine, but I wondered if those that had experienced trauma early in life compared to those that had not, if they were different, because they both had depression and migraine. And it was not too big a leap to find out that, Faith, that they had, the group that had the abuse history, they had more severe depression, more hospitalizations for depression. Depression occurred earlier, and the same with migraine, more severe migraine, more refractory migraine, younger age of onset of migraine, and, anxiety too. And I just think that, we really sort of have to start looking at some of these factors combined together and see, like, are the treatments, does it make a difference in treatment? We're a ways away from that there, but I think that that's how we can really probably help people once we identify these things, is if we, know the answers to some of those questions.
Absolutely. I mean, clinically, when I have patients who identify as transgender, who tell me a bit about their trauma history or just history of discrimination and stigma, I do find clinically that the combination of pharmacologic therapy for their migraine, as well as non-pharmacologic therapies such as CBT, mindfulness-based stress reduction, and those kinds of things really can be incredibly helpful in terms of improving quality of life, reducing migraine-related disability. I mean, obviously that's just anecdotal, but I can imagine that employing a multidisciplinary, multimodal treatment plan for these patients would be ideal, especially, in light of some of the information that's been presented as part of this study. I think really just the biggest thing is that the investigators looked at the SGM population. We need to do better at including these individuals in our trials and in our studies so that we can actually get a better assessment of their primary headache experiences as well as their non-headache experiences. And actually, as you suggested, compare to the cisgender population to really know, are they experiencing more trauma, different trauma? Is that really affecting their headaches more significantly than we realize? I wouldn't be surprised if they were, but I think this is just one big step in really just at the very basic, including these individuals in a study so that we can really understand better how to help them.
It's an important study. I think, when they acknowledge that they've got so many other things that they could, look at and add to, but I think it was a great start for getting people interested and aware of, some of the things affecting this particular population. And as you said, a lot of us see people with migraine, and we don't really know anything about their gender identification or sexual orientation. And, knowing that, especially if that looks like that is associated with, I would think it would be more discrimination in the workplace and in their families, even that, knowing the effect that has. And I think it's probably mostly through, stress related things, but, there may be some hormonal things as well in these populations that have effects on things like headache.
Absolutely.
Did you have anything else that you wanted to add?
I don't think so. I think we covered quite a bit. I think, it just hopefully will spark interest in a lot of the people who are reading this article to think about the SGM population and hopefully include them in more studies and trials going forward, as I said, so we can really just better understand their experience of headache and really help them, and cater their treatment plans based on some of the factors that could be contributing. I think there's just a lot of opportunity here that comes out of this study. So hopefully more and more will come about from this, and we can continue to move forward and create more inclusive practices as part of our research.
Well, thank you for doing this with me, Anna. It was really a pleasure talking with you about this study. And I learned a lot from you through the course of just doing this. It's nice to get another perspective.
Learned a lot from you as well. And so thank you very much for having me. And I really enjoyed this conversation.
Bye-bye.